inhibitor failure. That's where we got into these RAVs, R-A-V-S, and where a triple salvage component, where now you're getting a pan-genotypic protease inhibitor with a polymerase inhibitor, along with a newer NS5A inhibitor, is much more likely to work. Drug interactions, fortunately, in general, not a problem, but they focused on things like the proton pump inhibitors, omeprazole, etc., because when you reduce the acidity in the stomach, there's some data, and of course the competition's come out with this, but there's some data to suggest that you're not absorbing the NS5A inhibitor as well, so they try to keep people off of those when you're treating. There are certain herbal components. There's milk thistle that they don't want them to take. There might be some interference. That's in trials. In the real world, many people are still taking it. But what you want when you've got somebody on treatment is you want compliance. That is critical. That they're taking their medication and that they take it religiously. One of the advantages of shorter treatment, and in a naive patient who's non-cirrhotic, often they're on treatment for 8 weeks and they'll do well. They have high SVR rates. Versus somebody who has to take it 24 weeks, there can be a compliance issue. But if they're just taking one pill, it shouldn't be a problem. But you have to really preach to the patient there. Now, right now, most of the people treating are specialists, either a gastroenterologist, hepatologist, or infectious disease. It clearly is going to go out into primary care. Now, what is going to be the big thing for a primary care physician? If the person has HCV-RNA, you're talking about often giving them a pill for so many weeks, period, and they're not going to have side effects. But if they have cirrhosis, that person has to be followed after they're cured for the possibility. Here's another sleeper. Oh, I saw you sleeping on me. Another. That's the problem of getting cancer of the liver. The odds are much less that they're going to get cancer once they're cured, but they have to be monitored. So when it gets to primary care, I think what you're going to want to do is at least get something that says they don't have cirrhosis. One thing that you're seeing more in the United States now, is very prevalent in Europe and Asia, are fibroscans. They're not perfect, but they're non-invasive, they're point-of-care testing, and you usually have a good idea if the person has cirrhosis or not. You get something like that and treat them. If they don't have cirrhosis, they probably do not have to be followed anymore for their liver, unless there's a comorbidity. Okay, decompensated cirrhosis. This is more of a problem in transplant centers. Decompensated cirrhotics, the worst would be what's called a Child-Pugh-C. Child was Gardner Child, Michigan. These are people that, even if you get rid of the virus, if they're not transplanted, many of them will die. You can get rid of the virus in it. They're not as easy as in a well-compensated cirrhotic, but in most of them you can clear it. But they need to be transplanted. So what happens? In the transplant units, where you have more people waiting than are going to go get livers, they go by the MELD score, which, as you know, incorporates the INR, which was the reflection of the proton, the creatinine, because the ones who really decompensate start going into hepatorenal syndrome, and the bilirubin. And when the MELD, it's a formula, when the MELD score gets to be 15 or higher, they start being seen in a transplant unit and followed. And then it's going to come down to what their particular blood type is, what their size is, and what their MELD score is. And when a donor liver becomes available, there's going to be competition to get that liver. So some people who might have a MELD score of 30 and be a Child-Pugh-C, they rather not improve the MELD score because they're not as competitive. That's the kind of thing that's happening. And remember what I told you, if they don't get treated before the transplant, they certainly can be treated afterwards and clear. However, there are people on the list who, when you clear the virus, may come off the list. And these are usually not Child-Pugh Cs, but a Child-Pugh A, certainly, a cirrhotic on the list. Maybe it's on there for cancer of the liver. And there they've modified this. They don't transplant them quite as soon, but I've had patients who were treated while waiting on a list, and they had well-compensated liver disease. The cancer was taken care of by an ablation, radiofrequency ablation, or chemoembolization, and they didn't want to be transplanted. They're very active people. Now, that's not most of them. So, treating people on the list is very important, but when they get real high, often they would rather get that, the doctors as well, would rather have them be transplanted first. So that's a practical issue. Now, I've left about 15 minutes here for questions. Now, I better get questions. No, because if I don't, I'm calling on you. And I mean, I want questions. So let's start right now. Let's have a question right now. Don't tell me you want to split because you got a bigger lunch hour. Now, I want a question. Questions. Yes.
What about our HIV population?
HIV, I'm glad you asked that question. You know what's wonderful about this? Is the HIV co-infected people do just as well as those who are not co-infected with HIV as far as clearing the virus. And all these agents, the only practical thing with HIV is you got to look at drug-drug interaction. But with some of these new ones, it's not big. In other words, it's easy to modify. But the point is they will respond as well as the non-HIV-C positive patient. And that is wonderful. That's what's happened with the direct antiviral. So their outlook as far as C is concerned is much better. Let's have another question. Yeah?
How about the payment systems? Are we able to afford it?
Payment.
Everybody
Okay, no, this is it. What you're going to see is more and more of these payers are going to cover it. And often, even the co-payment is paid. They'll say there's a foundation. The foundation's really getting money from a pharmaceutical where they don't even have the co-payment. That goes on a lot now. Now, what do you have to do to get something for your patient right now? What most people have to do is get some kind of specialty pharmacy. And there's certain specialty pharmacies that are good with certain payers and other specialty pharmacies with other payers. Now, the PAs, the nurses, I got an ARNP who probably has more experience with this than anybody in the state, where you get specialty pharmacies putting all these forms out. You know, they're making it hard for you, submitting for it, and if they reject it, who then challenge it. Now, if they really challenge it, most doctors don't have the time to go what we call peer-to-peer. Well, I've been around a long time. I got people that I've had for over 30 years. So I'm very, very emotional about supporting these people. Look, I got a man now, he's an attorney, he's a hemophiliac. He's got C, he doesn't have advanced disease, but come on, let's treat the man. So what happens with me is I'll get a peer-to-peer. Well, the last one I had, who was my peer? Was a physical therapist. Well, I'm not knocking physical therapy, but she didn't know much about hepatitis. So I told her everything, and then I said, if you had hepatitis, do you want this? She said, I sure do. In fact, I agree with everything you said, but if I approve this, because the patient doesn't have cirrhosis, I will be fired. I mean, that was the bottom line. So you have to keep challenging these things. Now, some of this is helped out by the American Bar Association. It's a class action suit where the person was not given the drug and got into significant complications as a result. What you're going to see, though, is more and more loosening up of the payers. And it's going to get easier. Right now, it's not hard if a person has cirrhosis, even if they have bridging fibrosis. If they have mild disease, you got to fight. Some of them will take care of them. Well, the VA does, but but you have to fight for them. So that's your problem right now. But it's going, remember I told you this, each year it's going to get a lot easier. But that's a very practical question. Yes?
This is another problem with our patient population, besides financial compliance, other compliance assistance programs, most of the companies that you call, any problem, take your pill, or...
Yeah, put it on the mic there. I'm half deaf. Okay, let's hear it. Let's hear it. Give it again.
Just as big as financial problems for our patients is compliance. Is there any programs that the company?
Oh yeah, there are programs where if they have somebody, for example, who's on Medicaid, of course they have to show that they're busted and all that, but they pay for it. But there are a lot of people that don't get that done. But there are programs. All these companies have programs.
Somebody to call them every week, make sure they get to an appointment. Or
Well, sure, you got to give them a call. What are you not calling them? Or do you think Santa Claus is going to bring it to them? Okay, yeah.
A question about patients.
What?
There is a program in medical center for people with no insurance. There's 350 cured hepatitis C with
Yeah.
no payment. The patient did not pay a cent.
Let me tell you what also happens. You get these things out of India. Now let me tell you what's going on right now. And it's frustrating to people here. In India, there are 17 companies that make legitimate drugs. It's legitimate. But can't use it in the United States. Unless somebody got it. But you got to be careful because although there are generics out there that unquestionably work, there are also some counterfeits. Now there was a presentation at the European Association for Study of Liver Disease, and they just had this in Barcelona. And a man from Australia talked about this. He got a standing ovation. And what he does is when someone says they can get this stuff for $250, he says, send me some. He has it analyzed to see is the polymerase inhibitor in there. What it is, he says you can use it. And what's happening is that kind of thing is spreading around. In the United States, you can't do that. They did have some people from the United States who were getting it. But in general, I wouldn't recommend that. I think because of things like that, it's going to be more and more pressure to back off here. It's going to be better. Now, this thing you talked about was $350?
No. There are 350 patients cured.
Yeah.
With the pharmaceutical company providing the drug for free.
Oh, yeah. No, that goes on. That goes on, yeah. No question about it. Yeah.
In an analogous way with HIV, when we
Ryan White Act, that was different.
Well, I talked
Yeah.
with regard to the resistance. Is there something analogous with hepatitis C that we pre-screen them, like the genotypes we do with HIV?
No, the infectious disease people in particular are very worried about this, but it turns out that most of the people that have these RAVs at baseline are cured with what we have now. But there is a group that if they fail, you would want to know resistant variants. Because there are other regimens, like if it was an NS5A, you want to make sure there's a pan-genotypic protease. The polymerase inhibitor, they're all become negative. But it's that other one you're combining it with. But it's not nearly the problem that you see in HIV. I want another question. Where is it? Right here. Let's hear it. Give him a mic because I can't hear it.
You can hear me. Is it?
I don't want you to lose your voice. Go
No,
ahead.
no. Just a question. When you see these patients with hepatitis B that have mixed infection,
B.
hepatitis or A or C with either B or A, how does your treatment regimen change?
Well, A you don't worry about because A doesn't go chronic.
Does it exacerbate to C though to have
Okay,
that?
B and C, there's competition. Now, most of the cases don't have both of them replicating. What you'll see typically is in a hepatitis C patient, somebody who has core antibody for B. Now, that person has a component of the B virus sitting in its nuclei. It's called cccDNA, covalently closed circular DNA. In general, it's not going to be a problem in terms of treating the C. But when you get somebody who actually has HCV RNA and HBV DNA, most of them don't have that. If you knock out one, the other really takes over. It's like they were competing. So you got to be very careful that to be able to cover both of them. but that can happen, where the other one really takes off. Now, while we're on that core antibody, and we have this group here, when you're using immunosuppressants, whether it be for rheumatoid arthritis or inflammatory bowel, rituximab, or cancer chemotherapy, screen these people for B ahead of time. Now, certainly if they have surface antigen, nobody would argue with the fact that you treat them prophylactically. You could use tenofovir and entecavir for a week before you start it, because if you don't, there's going to be a group there where the virus rapidly reappears, and it can even be fulminant hepatitis. Now, don't mess that up. That's important. Where there's some controversy is if they have core antibody only. Now, I would treat them ahead of time, because a subset of those people will do the same thing. But if you're not going to treat them, monitor them carefully. That's very important. Now, we got away from C. There was another question. Yeah.
Well, for C, there is no vaccine, and for
No
B, there is no
vaccine.
treatment. Why can't there be treatment for C, for B, and vaccine for C also? Because
Why isn't there a vaccine for C? I'll tell you why. First of all, with B, the vaccine covers all the genotypes. There are different genotypes of B. For example, in Asia, it's B or C. In the United States, West, it's usually A. The vaccine for B provides antibody that prevents against any of them. C is another story. C, there are right now about 7 genotypes. We think of 6, but there's probably 7. Now, within each genotype, there's a spectrum of molecular variants that we call quasi-species. And there is no vaccine that has been developed that prevents against each of these variants. I'll give you a case in point. Study was done, it was done with chimps. You can't study chimps anymore. But where the chimp has C, and chimp was a hero of hepatitis, A, B, C, D, and E. I'll tell you why you can't treat chimps anymore. And that chimp was treated effectively, and the C went. The chimp was re-exposed to the exact same strain that the chimp got infected with. No problem, because they were cured. But then they gave a variant within the same genotype, but a different specimen got C, and that's what happens. And so you raise a practical problem where you really want vaccine, and that is in people who really are drug abusers and they got a problem now. What you would do, first of all, you want to treat them. And they are trying to do things to prevent them from getting reinfected, whether it be certain partners who are also treated. It's difficult. But what you ideally would do is treat them and then vaccinate them. There is no vaccine. That's where you really want a vaccine. But the problem is this spectrum of quasi-species. There's nothing that prevents it. If it prevents one, will prevent the other. You don't have that. Another question. I want another question. Yes, good.
Does the new NS5A inhibitor have the same problem with acid suppressive therapy? And if you are to need acid suppressive therapy, are you just going to use, like, say, omeprazole, which was studied, or can you go and change it with, like, protonix?
Now, when you're talking about omeprazole with the new NS5A inhibitors, there's controversy about it in the first place. But until proven otherwise, they're going to tell you to avoid it. Now, what would you do if the person has to take it? Let's say they got really bad reflux and have Barrett's esophagus. What you do is you give them the C drug, the combination drug, in the morning with the omeprazole, because that's getting through before the omeprazole has changed acid secretion. In other words, give it to them together right in the morning so that when they take the direct antiviral, it's already been absorbed before the acid, the pH actually went up. But in general, don't do it. But if you have to give it, do it that way. Okay. It's been a pleasure being here. Wait a minute, no, it's over my head. Don't do it. Listen, now wait a minute. Here's what I want to tell you though, seriously. We're living in a time when what's happening in hepatitis C is truly amazing. And you're going to see this eventually be eradicated from the globe. Thank you very much.
Gene,